Welcome to a Perspective Roundtable from the New England Journal of Medicine. I'm Atul Gawande, a staff surgeon at Brigham and Women's Hospital and an associate professor of surgery at Harvard Medical School and of health policy and management at the Harvard School of Public Health. One of the key goals of the current healthcare reform effort in our country is to achieve universal health coverage, but everyone agrees that it will be impossible to afford healthcare for all, even afford it for those who have it now, if we don't find a way to contain our very high and rapidly rising healthcare costs. Today, we want to discuss the economic dimension of healthcare reform. How can we reduce overall healthcare spending, or at least its growth, before it bankrupts the country? With me here to discuss the economics of healthcare reform are Elliott Fisher, a professor of community and family medicine at Dartmouth Medical School and director of the Center for Health Policy Research at the Dartmouth Institute for Health Policy and Clinical Practice. We have Jonathan Gruber, a professor of economics at MIT, and Meredith Rosenthal, an associate professor of health economics and policy at the Harvard School of Public Health. So let me start with you, Professor Gruber. Is it actually that important that we reduce how much we spend on healthcare?
In the long run, cost control is what it's all about, because ultimately the federal government will be bankrupted by the cost of medical care. Here's one simple example. Just to pay off what Medicare is going to owe under projected law with no changes, we'd have to raise the existing payroll tax rate, which is a little over 2%, to about 14%. And that's under very conservative projections, actually. So if we want to keep our fiscal system in order, we need to control the cost of healthcare.
Well, but if this is what it takes to save people's lives, and if it's taking more of our economy, and this is what people want to spend their dollars on, we're spending more and more dollars on little tiny electronic gadgets, why not on healthcare?
If you want to take that perspective, then we need to move to a system where voters and consumers understand that set of priorities. That means, for example, not including a bunch of subsidies towards healthcare that are sort of hidden in our tax system and our spending system, but making clear to consumers what they're spending. If in that situation, America decides to devote 50% of GDP to healthcare, great. What's more important than your health? But we're in a situation today where Americans don't understand what they're devoting to it and don't understand they're not really getting the value for their dollars.
Professor Rosenthal, do you agree that inflation of healthcare costs is this fundamental as Professor Gruber lays it out to be? And if so, what are the kinds of options or strategies we have if you do agree?
I think surely this is true, and I think aside from the public burden of increased Medicare and other government spending on healthcare, I think we have to recognize that the high and growing cost of healthcare also means that we can afford to cover fewer people and to subsidize less the healthcare for the low-income folks. Even if we do get universal coverage, there are going to be serious equity implications for high-cost growth. So I think looking at reforming the healthcare payment system would be number one on my list for ways to start approaching cost control. But I think more broadly, we need to have a more open societal dialogue. I think going back to what John said about what our priorities are, and we have never in this country been comfortable talking about rationing explicitly. And I think there's a need for that dialogue informed by evidence.
So I'm interested that the first place you went to is the payment system, how I get paid as a surgeon. And that implies that our payment system, when we think about the runaway healthcare inflation problem, that the payment system is the root cause of it.
Well, of course, it's complicated. The payment system interacts with things like norms and other aspects of the institutional nature of healthcare. But we have very good reason to believe that because we pay for units of service, for visits, for surgeries, for days in the hospital, that we get more of these things. And there's good evidence from experiments and natural experiments that show very significant changes in patterns of healthcare when payments change.
I think it's a subconscious influence on the way many of us practice, and a lot of it is driven by the environment within which we practice. Hospitals are paid the same way, and hospitals need to balance their books and often are recruiting more physicians who have provide services that have higher margins, that are more profitable, so that the hospitals can balance their books. But I think the way it influences our practice is in very subtle ways. Medical care system currently, fee-for-service does not pay for us to have long conversations with our patients. When we're feeling constrained, as many of us are in the current system, price for an office visit isn't very much. It's much harder for us to have that long conversation with a patient with heart failure to see if we can safely manage them at home. The default position in many communities becomes, gosh, I'm too busy, I better send them to the emergency room. The emergency room physician recognizes full well that they don't have time to manage the patient with heart failure in the emergency room, so admits them to the hospital. To the extent that those resources are available for us, and we're not paid to do the things that we really would like to do or know we should do, we see huge differences in the likelihood of really unnecessary hospitalizations in different communities.
So if payment systems are one of the core things to address, how do you address it? What are the proposals that are actually out there being offered? And John, I think you're being asked to actually make cost estimates based on some of these proposals and what they're going to do.
Okay, the right answer is Managed Care 2.0 done smart. And by done smart, what we mean is the following. A, smarter on the input side, which is don't just pay a flat fee, pay in a risk-adjusted way based on what's wrong with the patients. And the second change is on the output side. Don't just reimburse them a flat amount, but reimburse them based on the quality and the value of what they deliver. And put it together in what we call an accountable care organization. We know what to do. The problem is we're pretty far from legislative language. And there's nothing that, quite frankly, can be in a bill by October 15th, or by November 15th, or probably even in the next couple of years. My feeling is, as we look to this round of reform, the science of coverage has gotten so far past the science of cost control that that's why I feel like the president, at one level, did a bit of disservice holding up cost control as such a key feature of this round of reform. Because quite frankly, we can't do yet what Elliott wants us to do. We know theoretically what to do. What we need to do in this round is set the predicates, set the landscape so that that can happen. That means, I think importantly, setting up institutions to study comparative effectiveness so that we can get that information in place. And importantly, in my view, making consumers more cost conscious so that they're more receptive. Until we're willing to tell doctors and their patients they can't have everything they want, we can't control costs.
Boy, I think there's so much unnecessary care in the current system that right now we can give patients everything they need and would want if well informed. I'm absolutely convinced. I don't think patients want unnecessary hospital stays. I think they'd much rather stay home than go to the hospital when they have heart failure. And we as physicians would much rather be able to take care of them in ways that are safer for them. I think the payment system and a number of other things, our sort of cultural norms in many places, drive us to do unnecessary things.
There is no solution like put everybody on salary. That'll solve the problem. We first of all, we're not sure that works. But second of all, we don't know how to do it in a safe way. So what is a possible next step?
It's not just that we don't know what the end goal should absolutely look like. Even if we knew the global payment system risk adjusted with quality incentives at the end of the day that we'd like to see, we have a delivery system that can't operate under that payment system. We have a very fragmented delivery system, and obviously conversations about accountable care organizations is part of trying to knit that together, but there needs to be a transitional payment model that would be paired with a transition in the delivery system. And I think most of the proposals along those lines involve bundled payment of one form or another. Bundling payment for readmissions with the primary admission is the smallest piece of that, but there are payment models like Prometheus payment that are looking to put together all the components of care for a clinically defined episode and try to get various clusters of providers, maybe acting as medical groups, maybe working together collaboratively to accept risk for those episodes. So I think that's the path towards a more global payment model.
Experimenting with these kinds of approaches makes perfect sense. Imposing it across the country as the way we're now going to pay everybody as of January 1, 2010 would cause havoc because we're still figuring out if it even works for a single disease. And so, first of all, what are the provisions in health reform that can push us down the path of trying these experiments?